For our last segment of the evening, I'd like to introduce VCSQI's two newest resources here, Jayna Eller and Dr. Deborah Nadzam, whom, if you were at the quality meeting, you might have met earlier as well. They are really part of our VCSQI grant team, but are a resource to all of us within the group as well. And so the main topic for our activity this evening will be person and family engagement and activation. Jayna has been compiling resources that will be put on a web portal, and then Deb's going to lead us through a more interactive exercise to brainstorm some of the root causes here. Jayna, do you want to give an overview of the website?
So we're gathering resources that can help to streamline the information sharing process of your care team with the patient and their family members. And one of the key messages is to engage them in the conversation at the very beginning of the care process, that they ask questions and that they get the answers from you that they need to be a partner in the decision-making process. We're trying to identify and aggregate STS, American College of Cardiology, and NIH, other identified resources that can help do the video explanation, that it's a lot better to receive it that way than with a lot of heavy text. I've put up here on the back something that we went through in the quality committee, and I'm already getting good feedback. This is just really a PDF document pasted to the board. It's the beginning that would go eventually to go onto a website that could be accessed by patients and their families on multi-platforms, a smartphone, a tablet, or the internet by a computer. It's also something that could be downloaded as a PDF. It could also be printed out to be made available as a handout or in the waiting room, whatever is appropriate. The resources are identified all the way down to some suggested questions that you might want to ask your cardiologist and your cardiac surgeon in order to what to be prepared for, how to be prepared for when you go home, what do you need to know about your medications, what are your options, and then some resources that are available, like there's an iTunes app that can help you to be reminded to take your medications. Anyway, just kind of a first draft at trying to gather as many resources as I could identify with the input of the rest of the team. We've put them out there, and I'm now going to start collecting feedback. And one of our end goals is to become more engaged with our patients and their family members, that they can tell us if this is meaningful and what they really need and is useful, and if they can give us other suggestions as to other resources that we can continue to increase what we're able to offer. So that's what we've been working on.
Okay. So if you haven't seen what's back there, and Jayna, you were going to send it out electronically to everyone as well, right? So they can go on the links. And
one of the key things is it has about 40 links. So it takes you from where you arrive, and it gives you an explanation as to what you're going to look at, and then it can give you an example of the test or more information about all the different details. So it's just an entry point for much information.
Okay. All right, so I think this is worse than being the last speaker before lunch. This is like the last speaker before you get to leave. So let me see if I can figure this out. Which one is it that moves it? Okay, so this was supposed to be 45 minutes. Now I'm going to talk even faster and try and get through this in 30 minutes. And there'll be some other changes from what I thought we were going to do in the interest of time and getting you out on time. But we're going to quickly review the TCPI goals, primary and secondary drivers, and guiding principles related to patient and family engagement. Review the PFE criteria, patient and family engagement criteria. Aggregate results of the survey that some of you completed that Eddie sent out. And then rather than a gallery walk, how many of you were here when we did the readmission gallery walk? Okay, we're going to do a gallery sit to save time. I'm going to innovate. I've never done it this way before, but that's part of being a workshop facilitator. You've got to look at the room, and this room is the worst room I've been in to try and do a gallery walk. So we're going to improvise. And then relate key factors to the change acceleration practice. So you've heard a bit already today and tonight about transforming clinical practice improvement initiative out of CMS. It makes me want to say ABCDEFG supercalifragilisticexpialidocious, a whole new set of words and acronyms that we all have to get up to speed on, not mentioning mathematics. So you can read this. Eddie will send out these slides ahead of time, but in essence, it's to move 140,000 clinicians in their practice transformation work over the next few years, build evidence based on practice transformation so that the solutions that these first 140,000 realize can be scaled to the rest of the clinicians in the nation, improve outcomes, reduce unnecessary hospitalizations, sustain efficient care delivery, by reducing unnecessary testing and procedures, generate $1 to $4 billion in savings to the federal government and commercial payers, and transition 75% of practices to the alternative payment models. There are 3 primary drivers to TCPI, and I think this is one of the handouts that Eddie had in the back, 2-pager. The 3 primary drivers: person and family-centered care design, continuous data-driven quality improvement, and sustainable business operations. There was certainly realization that bringing costs down could bring quality down, could bring patient experience down, which is why these other factors are part of the whole initiative. Cost-effective care is lower cost, but better outcomes, or higher costs with better outcomes. It's cost-effective. So for each of these primary drivers, there are secondary drivers. You can see there are 7 that relate to patient and family-centered design, 4 that relate to continuous data-driven quality improvement, and 4 that relate to sustainable business operations. I don't know. What?
So patient and family-centered care design. I think you've been engaged in that for a long time, and I think that that's a primary interest of CMS right now. And can you
We're going to
make sure that you do that?
We're going to talk about that in greater detail. But you can see that there are 7, 11, 15 secondary drivers. And that practice assessment guide that we touched upon a little bit at the end of the quality session that Eddie will send out to everyone addresses all, what did I say that was? 15 of these. So that you would be scored on each of these secondary drivers to see where there are gaps. So it's like a gap analysis to determine where do you need to keep moving in order to really get to the advanced APM. So, backwards. What is patient and family-centered care? When an organization's culture considers, sorry about that typo, patients and families' values, perspectives, wishes, and input into care decision-making at all levels of patient and family engagement. A key word here is shared, is decision-making there. This is really moving faster than I want to move. Come on, you can do it. Okay, what is patient experience? The Burrell Institute is about 10 years old. And they describe it as the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care. Patient satisfaction is an old phrase. It's not the working term these days. Because when you talk about satisfaction, often you get into food and parking and all that stuff. Patient experience is really what we're talking about. What was their overall experience related to the care they received? And what is patient and family engagement? It's a set of behaviors by patients, family members, and health professionals, and a set of organizational policies and procedures. This is ARC's definition, that foster both the inclusion of patients and family members as active members of the healthcare team and collaborative partnerships with providers and provider organizations, all to improve quality and safety within a healthcare organization. I mean, it's pretty amazing to think that there had to be a patient safety movement, isn't it? And that there had to be attention given to including patients in their care. I mean, how far have we moved away from, asking the patient what they want and involving them? Or protecting the patient, right. First, do no harm, right? Okay. Where am I? Am I supposed to aim it someplace else? Okay, so PFE accelerating TCPI results, patient and family engagement, accelerating the results for the transforming clinical practice at the initiative. So there are your three primary drivers, and these are guiding principles for addressing consumer priorities and value-based practices. I think this might have been on, was this on one of the handouts that you gave as well? Okay, so you can see 6 points here, 6 principles. Include patient consumers as partners in decision-making at all levels of care. What does that mean? That means at the bedside, in their own level of care, their own care that's happening. It means on committees in the hospital that are making decisions, on your patient safety committee, on your quality improvement teams, and it means at the governance level. A lot of attention has been given to this for hospitals over the last several years. Those of you from hospitals probably have heard this push to bring a patient onto your quality committee, to get a real patient on the board. The argument is always, well, yeah, everyone on our board gets their care here, their patients here. That's not the point. The point is a patient or a family member who's sitting there with those ears, not with the typical board member responsibilities, although this person should have those same fiduciary responsibilities. Mm-hmm. Who's a consumer?
Yeah, I don't like the word.
Well, it's a consumer of healthcare products. Someone who uses healthcare, yeah. I guess it is a government term. It's a government slide. The second principle, deliver person-centered care, where you really are focused on that person and their values and their preferences and goals. Design APMs that benefit patients. Drive continuous quality improvement, accelerate use of person-centered health information technology, the heart card that you heard talked about and passed around at the last meeting, and promote health equity for all. Next. Okay, so this is just a snapshot of the practice assessment tool, highlighting 2 of the criteria that focus on patient and family engagement. You'll see it's driver 1.1. There were 7 secondary drivers for patient and family-centered care. So you can see there's scoring at the top, and as you move to the right, your level of patient and family engagement is higher, is more sophisticated. So, for example, over here, 0, practice does not regularly utilize shared decision-making or other tools to encourage patient and family involvement in goal setting or decision-making. If you move all the way across a 3, practice can demonstrate that patients and families are collaborating in goal-setting, decision-making, and self-management, e.g. shared care plans, documentation of self-management goals, compacts, etc. So that's how this practice assessment guide works, and these are just 2 that specifically focus on patient and family engagement. Next. Okay, there are 6 metrics. Aside from being evaluated on criteria, if you're in this game, in one of these practice transformation networks, hopefully the VCSQIs, there are 6 measures that you can utilize that I don't think data will be sent on these. No, I guess we can send it. What we want to know, government speaking, what CMS wants to know is, let's say that VCSQI Support and Alignment Network has 60 practices enrolled from wherever. So we would report the percent, the number of practices of the 60 that have that use an e-tool, I want to get out of the parentheses, that is accessible to both patients and clinicians and that shares information such as test results, medication management lists, vitals, and other information and patient record data. So that's the first measure, the use of an e-tool to share information with both patients and records. MyChart.
What do you mean by
MyChart. I mean, that's what I use back home. An electronic patient portal. The second measure, also at point of care, does the practice support shared decision making by training and ensuring clinicians integrate patient goals and preferences related to culture, language, religion, emotional, and economic status into the care plan.
So you got to just pause right there. I think that's probably the most important thing that you're saying. That we need to engage our patients in shared decision making, and we need to take in the multicultural, different religious things that people are engaged in. And we need to be sensitive to that.
That's patient and family engagement at the bedside level of care. Are you really incorporating their wishes, their values, their needs, their goals into the plan of care? The third measure, the first of 3 in policy and procedure, does the practice utilize a tool to assess and measure patient activation? I'm going to talk a little bit more about that in a minute because patient activation might be a new term for some of you. The next measure is a health literacy patient survey being used by the practice. I'll talk a little bit more about that in a minute too. The third, under policy and procedure, does the practice promote patient-centric medication management practices? Self-management of medication. Is the patient really taught? Are they expected to manage their meds in a very disciplined, well-taught, understood way? And then the last one is governance. Are there policies, procedures, and actions taken to support patient and family participants in governance or operational decision-making committees of the practice? So these would be like, now they're being called Person and Family Advisory Councils. We pronounce that PFAC. A lot of hospitals have them now because it was the emphasis of a previous CMS. Well, it's still undergoing. Is Premier still a hen? Premier is still a hen. And
Can you define patient activation?
I'm going to get to that. I said I would get to it. Okay, but also, besides having a Person and Family Advisory Council, do you have a patient on your safety committee? If you know you want to improve throughput in a hospital for cardiac surgery patients, do you have a former patient or a family member on that improvement team? And finally, is there a patient or family member on your board of governance? That's the toughest one to convince people to do. Okay, what is patient and family activation? Laurel and Hardy here, huh? Okay. When patients and families have the knowledge, skill, ability, and willingness to be an active partner in their care. And I'm going to show you where you can get some resources on that. It might be next. I added some slides. This is one that my daughter uses, actually. She's a patient and family advisor at university hospitals and helps the Ohio Hospital Association. Okay, so it was really tough to find this slide because this is it's managed by a company now. It's real low cost to do, but I had to really search the internet to find an example with the actual questions. With patient activation, there are 4 levels described, and it has to do with how knowledgeable, capable, and willing the patient is to actually manage their care. So level 1, when all is said and done, I am the person who is responsible for taking care of my health. Taking an active role in my own health care is the most important thing that affects my health. So these are scored. I think I have it on the next slide. Predisposed to be passive. So the answer examples here are strongly agree, agree, disagree, strongly disagree. So depending on how the patient answers, the very first level of activation is whether or not they are even interested or believe that it's not up to them to take care of themselves. The second level is building knowledge and confidence. Patients have some knowledge, but large gaps remain. They can set simple goals. I could be doing more is kind of the quote here. Taking action is level 3. Patients have the key facts and are building skills. They're goal-oriented. I'm part of my healthcare team. And level 4, maintaining behaviors, pushing further. Patients have adopted new behaviors but may struggle in times of stress or change. Healthy lifestyle is a key focus. I'm my own advocate. Judith Hibbard is the researcher behind this from University of Oregon and has shown that the more active a patient is, the healthier their lifestyle and the better they are for caring for themselves. So there's research to show, there's evidence that shows the activated patient is the more compliant and health-driven patient. Okay. So what is a Patient and Family Advisory Council, PFAC? I mentioned this before. This is ARC's definition. It's a formal group. This is not a support group where patients come to discuss their unique condition and needs. It's a formal group that meets regularly for active collaboration between clinicians, hospital staff, and patient and family advisories. The patients and family members bring suggestions to the healthcare organization, whether that's a hospital, a nursing home, a group practice, for how things could be improved. And the healthcare organization brings ideas to the patient and family group, saying, we're thinking of doing this, or we've written this document for patients, such as what Jayna has shared. Critique it for us. What do you think? Does this make sense? How can we really make it work for our patients and family members? But it's a very structured process. There's structured ways to find good patients and family members to bring to this committee. You don't want everyone who just loves you, because then you get no constructive criticism. But you don't want people who are in the middle of a lawsuit with your organization or really bearing a grudge of some type. They have done, across the country, as more and more hospitals have launched these, they're amazing stories that have come out of patients being involved in improving operations of hospitals. Okay, can I talk about my friends? Which friends? Yeah, have any of you heard of Bob and Barb Melizzo? You probably have. They sort of have become the face of patient and family engagement for CMS. When the whole Hospital Engagement Network Partnership for Patients initiative was launched in, I guess that's about 4 years ago now, Bob and Barb were the opening speakers at the first day of the National Quality Meeting in Baltimore. Their story is a very gripping one. Their adult daughter went in to have a liver shunt repaired. She was 30-something, I think, at University of Illinois, Chicago. This is, I'm not telling any secrets, this is all known. In the end, they had to pull life support from her. There was a miss in the OR of her oxygen level and carbon dioxide level going up, oxygen going down. And she was kept alive for a few days until her husband and family decided to pull the plug. The risk manager and head of anesthesia at the time was Tim McDonald. He locked down the OR. He was not in the OR at the time, locked it down so that nothing was changed, no garbage was emptied, and they did a full analysis and determined they made a mistake. They missed her heart rate slowing down, her levels changing, and long story short, he has made it his life's work to repay the Melizzos as best he can. They have added a seat in Michelle's name to their patient safety committee, and Bob or Barb, mother, father, or her sister are in attendance at every patient safety meeting to serve as that patient family eye, to help critique events that shouldn't have happened, that need a root cause analysis. And Bob and Barb have also made it kind of their mission now to work across the country to encourage patient involvement and to help healthcare professionals focus on reducing the risk to patients. And they are wonderful, wonderful people. I know he's the former mayor of Hobart, Indiana, and police chief, and you're going to get them to speak at some national meeting, right, Dr. Rich? Okay. Okay, so this is a little bit more about PFAC. You can keep going. We're not going to get into a whole lot of detail here, but I just wanted to make the point that these are formal committees. And this is one of the types of consuls that CMS is hoping group practices put together. Not just hospitals, but group practices. I floated the idea at the end of the quality meeting about a VCSQI, Patient and Family Advisory Council. And one suggestion was that maybe each hospital should have their own cardiac surgery PFAC first and pull a patient from those to sit on a VCSQI one. I think we should write up a little bit more and put it back out to the group. You could be, right. And others said, you know, well, if we're a real small hospital, it doesn't make sense to have more than one PFAC. So I think we can play with this, and it would put VCSQI out on the map again for doing something really different. So we'll.
Yeah, but even if you're a small hospital, it doesn't mean that you don't have an important voice.
No. The point being, you might not need a separate one at your hospital for cardiac. Wasn't against having a VCSQI one. Each hospital might have a different need. I'm not sure I'm explaining the difference, right? Okay. Where is he? Oh, there he is. Okay. All right, so let's jump to the survey. I think we're probably going to have to do a virtual gallery walk at some point in the future. I don't know if we're going to get to even a gallery sit given the time. But here's what 12 of you said. A 13 response came in yesterday, so it's not part of this. But we asked about those 6 measures and where you think your organization is. We asked you to try and answer with a group practice hat on, not your hospital hat. So I'm not sure how many of you were really able to separate it, and some things are hard to separate. If your cardiac clinicians are employed, you can't help but think, you know, the e-tool they're using is probably the hospitals, so it's a little bit of slippery room here. Okay, so first question. Does your practice use an e-tool that is accessible to patients and clinicians and shares information? So 2 of you, can you blow that up a little more? No, it's actually the other side where the whole sentence is, I think. 2 of you said you rely on face-to-face encounters and phone interactions with patients. Can you move it over a little more? 1 of you said you're considering the use of technology to offer alternatives to face-to-face practices. And these are, these answer choices are part of that assessment tool. Where I put those down as answer choices. Sometimes there wasn't a similar question on the actual practice assessment guide. Over a little more. In terms of practice has the capability of providing alternative types of communication media. What's the number? Can you see it on your screen, Eddie? 6? Okay, so that's half of you have the capability of providing alternative visit types or communications. And then I think it was 2 again. Practice offers multiple forms of alternative visits, email, Skype, or televisits. 3 of you. So 9 of you are pretty far along of the 12 who responded. Next question. Does your practice support shared decision making? 3 of you said you do not regularly utilize shared decision making. 2, practice is training staff.
Sorry, it's different on my screen.
Practices training staff in decision-making approaches and developing ways to consistently document patient involvement. Maybe you can, 0? 0 of you say you have, maybe you should read these.
Yeah, I'll read the responses. None of them say they've developed approaches to encourage and document patient and family involvement in goal setting, decision-making, and self-management. And it looks like 3 said the practice can demonstrate that patients and families are collaborating in goal setting, decision-making, self-management, for example, shared care plans, documentation of self-management goals, compacts, etc.
What was that first number up on top? It's not 3.
On top was 7 out of 12,
7.
58%.
Okay, so this, like you said before, this is probably an area that as a group, you might want to concentrate more on. How do you get shared decision-making in play with your patients? Next question. Does your practice utilize a tool to assess and measure patient activation? Why don't you just read it on your screen?
Yeah, sorry. So 2 or 17% said yes, 8 or 67% said no, and 2 again or 17% said I'm not sure.
So 10 of the 12, you either don't or maybe you didn't know what it was. And given the evidence shows that active patients are driven to be healthy and follow orders.
But don't you think that, part of the response about patient activation is misunderstanding?
Right. So there's room for education about what this is and then how to do it if you want to use it. Okay. Fourth.
For me, I think that everybody sitting in the room are thinking like, why are we talking about this? Because this is probably one of the more important issues that we have to face as clinicians dealing with our patients. Whether you're a physician or nurse practitioner or
when you put shared decision making.
I think it's our responsibility to sort of engage in this because this is the direction of our future. I mean, you know this better than me, and I would just want you to emphasize it.
Well, if you think about patient-centered care, you can't approach that without knowing more about the patient. How motivated are they to be involved in their care and to take action to stay healthy or get healthy? Do they
Ellen and I are sitting here like we're always talking about atrial fib or strokes and things like that, but we've never really engaged the audience and our involved clinicians in patient activation because we didn't know what it was and how important it is.
Well, it's a newer research findings about it. How many questions?
Of the people sitting here, how many of you would be interested in, because I'm listening to this stuff and I don't know about you, but I know nothing about this. I mean, my patient activation is you want to get operated on, And so how many of you would be interested in having patients participating in routinely in the VCSQI around this issue? That's it, half only? How many of you would be interested in having the safety officers from our different institutions participate here and have dedicated safety discussions, not just clinical, but as we're moving toward that as well? Okay, so a majority would like the safety part of it, but half would not like patients involved. Is that a fair response? So would anybody be willing to say if you don't want the patients involved, why? Anybody want to be bold enough to say to
No, I think that, Alan, the best question would be to get patients' involvement and get patient safety officers here to protect their intellect and their experience with patient safety, and maybe bring it forward as a something that might make a difference to us when we treat patients. Because, like you said, you don't know what it's all about. I mean, Debbie and I have been talking about this for months. I didn't know what it was all about, but I'm getting more and more educated about it. And maybe it's something that we should bring forward. And, I think that the answers to the questions would probably have more hand raises if we actually presented information and knowledge transfer about what we need to do.
What are you seeing about it from your perspective?
I've seen a number of hospital boards now that have a patient sitting on their quality committee. Yeah, as a hospital board or healthcare system board, you have to have a quality committee. More and more I'm seeing patients as an advocate sitting on that committee.
Can I just say something too? My name is Jill. I work for Bonsborough St. Mary's Hospital. I'm actually the cardiac surgery program nurse, but also the care coordinator. And we actually have our joint cardiac operational meeting, and we have invited patients to come share a story. We start every meeting with a safety story. So the physician, this week it was Dr. Pfizer, told a story that we were all kind of involved in, but the cardiac operational meeting with the patient there was amazing, you know, to share their perspective of how it went through. And that's the whole point of our operational meeting is every department that touches a cardiac surgery patient comes to these meetings. What can we do better? Where were our mistakes? What does the data look like? And I'm kind of, you know, been part of that. But I think it's excellent.
So, and you know, learning happens when, no, wait 1 second. Learning happens when emotion's involved. And when some of these stories are shared, ears open up, tears fall, and people are ready to hear more. Also, your Bon Secours St. Mary's toolkit for selecting patients and forming a PFAC is actually on the resource list that the patient engagement group of TCPIs put together. So way to go.
Yeah, so I'll just say that as past president of the STS, when I was president, I mandated that we put on the board a patient advocate, which is still there.
You're still hoping to fill that?
No.
Oh, you did? You got one on? No, I mean, that was recent, though, I think.
No, it's filled.
It is filled. Yeah. Great. Great. Okay, so the next one has to do with literacy, I think. Is a health literacy patient survey used by your practice?
So 37%, 36% said yes, 55% said no, and 1% said they were not sure.
Okay. There are some videos that would make you cry and laugh at the same time when you hear how patients interpret the words we use with them. I mean, you know, we've worked hard with some of the material that we've put together to try and get the medical jargon out, and I think we still have room to go, but you know how discharge is interpreted. It's not leaving the hospital, it's what's coming out of your body. I mean, just simple words like that patients have no idea what we mean when we use words we use all the time. Okay, 5. Does your practice promote patient-centric medication management practices? 6, yes, 4, no, and 2, not sure. So I think there's probably some good motion here happening where you're really making sure your patients can manage their own meds. And then the last question, are there policies, procedures, and actions taken to support patient and family participants in practice governance or operational decision-making committees of the practice? 3, yes, have a PFAC. 3, have patients and families in a person and family engagement and on their board. That's pretty cool. Yes, but only on a person and family advisory council. That was 1. 2, yes, but only on the board. That's really interesting. 5, no patients on either kind of committee, and 1, not sure. Are the 3 who said you've got patients on advisory councils and the board here? Don't know. Okay.
So what would you think would be the most effective thing to do? Like rather than have a patient family engagement at a hospital, should we have an advisory council for the VCSQI? Should we have a patient advocate or 2 or something that would help us guide and direct us in terms of appropriate care, caring care,
I think most hospitals have at least a generic patient and family advisory council now.
Where do you start? Do you start with like our organization, or do you start with each hospital?
I don't think, well, I think most hospitals have it already, so I don't think that's something that we need to deal with. You might not have one, they have a generic one.
Anybody else?
Does anyone have a cardiac PFAC? Who has a generic one in their hospital? Okay, so I don't know that you have, your idea takes merit, I think, and that maybe those of you with large services would benefit from a specialty PFAC of cardiac, focused just on cardiac. I don't think that that precludes having a VCSQI one, though. I mean,
Why not? Why wouldn't it get done for us?
oh, wait, what? No, I'm not saying this right. I think those of you who want a special one at your hospital should go ahead and do it. I think VCSQI should go ahead and do it also. It's just finding the patient. No, a cardiac one.
You're so much smarter than I am. Sure.
What's your question?
Should we have a VCSQI Patient and Family Advisory Council.
Or patient and family advisory person who could just sit with us and talk to us about we don't want to talk about AFib forever in our lives. We don't want to talk about strokes. We want to talk about what makes care more loving and careful for our patients.
I think that, yeah, as an editorial, just as a human response, I mean, we're hearing now in the last couple of meetings that we're going a different direction. What started out to be pretty simple of clinical outcomes coupled with financial, whether it's with cardiology and surgery, we took a left turn or a right turn because we've been avoiding or excluding or omitting all that we're seeing coming down the pike. You know, usually we were way ahead of things, and I'm feeling woefully behind things, personally, because we're not doing any of this in our hospital. We have still got our head in the sand, fee for service. It hadn't come yet. It's not going to happen in July. Power forward. But you know, to really not just win the Medicare game, but just be appropriate, we have to pay attention. You know, the survey only had 12 people, but yet the questions of the survey, I'm sitting here trying to answer, and it's like you were alluding. I don't know whether our health system does this or not. It's one of the biggest in the East. It probably does, but I'll bet you it's just not transferred. That data transfer isn't happening. So the box gets checked that the board's got something. How do I know? So I think that we need to re-engineer ourselves, include what you're talking about, give it a voice if we're going to be successful in what we hope to achieve.
Why don't we give patients a voice?
That's what I said. I'm sorry, I didn't say it. The answer is yes.
Why have we not done that? Because I don't think Debbie or Jayna has brought that forward to us until we finally realize that that's an important component of the way that we deliver healthcare.
Because we didn't give them, I think, the voice that should have been given. Because I'm a heart surgeon, and they did well. They lived. They didn't stroke. They didn't bleed, and they went back and were productive. Check.
Don't beat yourself up too much. I mean, you've done a lot of great stuff, VCSQI, but it's time to get ahead with this as well now.
Yeah. Ellen and I always talk to each other.
But it's not just us.
We look at gaps in the way that we deliver care, and this is one of the gaps that I want Debbie to bring forward and Jayna to bring forward, because I think that it's an important gap to close.
Yes.
I bet you the quality people and all, I don't know, I think the surgeons, we're probably over on one side. I don't know, do you agree or disagree? It's all of your meetings. What do you think? Kurt, have you thoughts on that? Other surgeons? And then, what do people?
I'd like to add one suggestion. I mean, whether you make it a long-term initiative to have a long-standing group that serves as your advisory council, or start with a focus group with representatives from your different institutions, even if it's coordinating a quarterly conversational phone call across, county lines to gather information from their individual perspectives. I mean, that would be a place to start that's probably pretty manageable.
What does UVA do, Kurt? Are you involved with any of this?
So I think we're doing the things probably everybody else are doing with bedside report, involving the patient and rounding and having the family come in with you round. I know there was the whole initiative of bringing families into further codes, and not doing it for open chest. I think there are things probably everything, that probably everyone is trying to do. I do think that we all have lots of room for improvement. And I would say, and I am all for having patients involved here. So my hand was probably the highest. I love the idea of having patients and their families involved. I think one of our concerns anytime, I think when you bring in and looking at that quality, even what's an OE ratio? Oh, well, Dr. Rich, look at your stroke rate. Like, how do you help navigate them? It's the same thing of bringing them into a code. Right now we're doing CPR. Right now.
I don't think that we should be teaching about OE ratios. We should be teaching them about communication.
Absolutely. But we're going to
care and making sure that they understand where they're going to get their care, how they're going to get their care. I'm not going to teach statistics.
But
and they should be teaching you.
That's right.
Right.
And they should be teaching me about what my deficiency about.
But it's just like, if they're going to be part of this meeting, though, will we still go over, you know, unblinded outcomes? Will we still be doing the same things that we do now, or we won't do those things now? So that's what I'm saying.
Yeah.
You know what you hear what I'm saying?
Yeah, yeah. Okay, so.
Dad, I mean, how would you engage a family member or patient family engagement? You bring them to the meeting and we share with them. Why can't we be transparent? We can teach them along the way. Why can't we be transparent?
I think there's so much we don't know about this that would be the least of, I mean, I agree with you. But if I just checked the box yesterday about public reporting in consumer reports. We're already doing it. There's such a paranoia about whether it's ANOVA stroke rate or their, you know, but there's so many more things than just that part of it, right, to me. Because, I mean, like you said, they need to be teaching us. And plus, there's a whole ethnicity that I don't really know about. You know, the different, I mean, the language, there's 43 different languages in my hospital on any given day. Well, I don't even know 43. I mean, how's that happen?
You can't name them.
I can't name them.
But it's multicultural. I think that we are obligated to treat the population that we treat.
And people are expecting.
We have to be able to communicate that.
Yeah.
Effectively. However you might think about it, Debbie, I don't know.
Here's one idea as an example. I've sat on the National Coordinating Council for Medication Error Reporting and Prevention since it began about 20 years ago. And a few years ago I said, where's the patient around the table? Because the organizations around the table are the AHA, the AMA, the Joint Commission, ASHP. I'm an individual member at this part. There are all these, the VA, the DOD, the FDA, you know, it's like, so I finally said, where's the patient? So we had a national patient advocate make a presentation. And this happened at the time, the person from IHI was the chairperson of the council, Frank Federico. And he's like, you know, oh my God, I'm from IHI. Yeah, where's the patient? So we had a presentation made about how a patient could be a valuable member to NCMERP, as we pronounce that acronym. And there's now a patient on the council. And sometimes the question is, because the council's talking about some medication thing, sometimes the patient says, why do I care about this as a patient? And it brings the group back to, why are we talking about this? You know, what does it matter? It teaches the patient and it helps the group kind of refocus about why does this matter? No, it is not. Well, it actually was Chrissy to start, but now it's someone else.
No, but I mean at the last TCPI meeting.
Bob and Barb?
Yeah, Barb and Bob.
They're heart patients as well, and they talk about that, so.
So, Deb already alluded to it, but I think it was probably the most tear-jerking moment. Do you think that we can get a copy of that presentation?
Oh, we could call it up on the internet right now, except we're already past time. But
I think it was close.
But they could probably do a webinar or come to your next meeting. They would love to do that. They would love to.
That'd be great.
Yeah, and they could first offer advice about how to have a patient in your group, and then you could take it from there.
I often hear about patient-centered care, and then we have all these committees and pathways and discussions and groups and task force, and we're talking about patient-centered care, and we always say, where is the patient? Well, the patient thinks this, the patient does that. We should have a patient in all of these things. I mean, when I first became a chief medical officer, and I would go to the C-suite meetings, you know, the CFO, the CEO, and they say, well, the physicians think this, and the physicians don't think that. And so we're going to do patient-centered care. We should have patients there so the patients can say what they think.
No, I agree completely with you. I think that absent our initiative in treating patients is that we're not having a patient voice there. I think it's so important. Debbie's talked a lot about this over the last several years, and I've come to really appreciate that. Thank you. It's really very appropriate and very heartfelt.
If I may say something, I'm Patrick Choate from Augusta Health. I think organizational support is also key. At Augusta Health, we have allocated multiple FTEs to reach out to the patients. We have a large deaf population. We just created a virtual interpreter for our deaf population. We've actually incentivized administrators and executives annual bonuses off of patient satisfaction. We put it at the forefront of every meeting. We bring patients to the board for positive stories and for complaints. We try to empower the lowliest person in the county to have just as much voice as our executives.
So do you have signers at the board meeting?
We have. If there's going to be a deaf person that comes to the board meeting, we do. Every patient that comes in that is hard of hearing, we first offer them an in-live interpreter. If they don't want that, we have a virtual interpreter. We have iPads that have interpretive services also.
Are they totally deaf, or do they have hearing deficits?
Most of them are totally deaf. We have a large school for the deaf and blind out there, so we have to cater to that. But we brought the school in and said, what can we do to serve you better? We put them at the forefront of driving change, but our administrative team supported that. And I feel like without the top-down support...
I mean, how do you do that? How do you actually do that? Where do you focus it? Do you bring patients together on a bus? How do you actually do that?
The first one was an email we got, and then we drove to their school, and we talked to them, and we brought them in. It's really taking the time, and I think there's extra FTEs of people who can just focus on that, because none of us have time for that. Just allocating those people just to reach out to the patients, hear them, give them a voice, and bring their voice to the appropriate people,
Right.
I think that speaks volumes.
And how many patients do you have who are deaf?
The school is the largest school for the deaf and blind in Virginia.
Where is it?
It's out in Stanton.
Where?
Stanton, Virginia?
Yeah.
That's a great example of community engagement too. Yeah, going out to the school.
They've, for a deaf population, they've had a large voice.
Well,
Wonderful.
Eddie.
Thank you for sharing, Hunter. And I think we're going to draw on you as a resource too to
Yeah.
provide examples to some of our other hospitals who might be trying to do similar things.
Excuse me, Eddie, can I ask one
yeah.
question before you close up? Because Eddie asked me if I could close the meeting. I've never done that before. So before we close the meeting, I wanted to ask a question, and it has more to do with what Deb's talking about, the patient action. How many of the hospitals that are remaining here actually round on their patients with a multidisciplinary team? They have care management, nurse practitioner, a navigator, the bedside nurse, the supervisor, and a physician. How many of you guys raise your hands? So are there duplicates, though, of centers there? I'm talking about on the floor in the ICU, but mostly on the floor. But if you aren't doing it on the floor, I would say in the most basic context of what Deb's talking about, you've really missed out on the opportunity, because that is the time to engage your patients before and after surgery and to ask the key questions. Audrey has a patient success protocol where she lays out the expectations to the patient and gets an idea as to how committed they are, and then relates that back to our care team, our mid-levels and our physicians before we even take them to the OR. So we have a pretty good idea who's going to want to participate in their care post-op and who's not, and what resources you have to align to take care of those people. And then after surgery, if you're not getting all those people together, then in the most basic context, why even go this point? You better be doing that before you get all this. All these slides, as Dr. Spear said, we have no idea what the hell's going on. Because that's the most basic context of care, is listening to the patients. Before we walk out of the room every day, we ask one question. Is there anything we can do for you? Is there something we're missing? And when the team walks out, I'll stay in the room and I'll sit down on the bed with them. I'll say, tell me what's going on. Is there anything that we can do for you? Is there anything we're missing? Especially people that don't look like us, that may have ethnic issues and have preferences or religious concerns or whatever. If you're not asking those questions, then you're really missing out on your opportunity.
And what are you hearing when you ask those questions?
We get a lot of feedback. We hear what they're afraid of. We hear what they don't understand that we're saying. We hear about their frustrations with the way we deliver our care. Mm-hmm. We hear about their frustrations about the most simple, most basic things, about the time the food's delivered. Just things that you're just really missing out on that most likely are totally hosing your and our HCAP scores. Yeah. So I guess a lot of these things that you can form a ton of committees. Believe me, I'm not against forming the committees, but you're missing out. The low-hanging fruit is right there, and you're missing it if you're not doing those things. That is the first side. Yes. Yep. So before you go doing all these things, you may want to go back and start doing those things and actually be transparent and genuine about it. Because if you just, there are times, I'm not going to lie to you, you'll walk in the room, and if you really don't act like you care, you're just in there to get out of there, they sense that. They can see it all over your face. It's being real and genuine. But if you don't stop and listen to them, then you're missing out.
So I love your passion. Drop it. I love your passion, but I'm going to personalize this because I had both my knees replaced and my spine reconstructed, and I'm not multicultural. I'm not look any different than you and I do. Maybe I have a mustache and you don't, but I can tell you that once I got out of the ICU, I felt like I was left behind. Like I was on the floor. I didn't have any personal contact from a nurse or nurse practitioner or a physician assistant. So I get what you're saying, but it doesn't have to be racial, cultural. It has to do with all of us as patients.
Were you left alone because they knew you were a physician?
Nah,
I mean, that's
well,
not right either, because you were a patient at the time.
I was a patient. I didn't.
Yeah, I know. But you know,
I did not advertise the fact that.
The title of this presentation was "Nothing About Me Without Me." That's not my slogan. I think that came from the Burrell Institute. But the other thing, when you think about it, at least in the hospital, who's the only one with the patient all the time? The patient. You know, maybe a family member if the family has decided somebody's going to be there all the time. But to not include their voice, all kinds of errors and things could be missed. So you're right. It's got to be at the bedside first.
I think there's just a communication gap sometimes.
Yeah.
Once you get out of an ICU, Ellen and I could take care of patients incredibly well in the ICU, but when they get out of the ICU, you kind of lose track a little bit. And
so
it doesn't seem, and I saw that, and I experienced that myself, and it was a little bit disturbing.
Sure.
But,
so,
because I was
we've got a lot of work to do, I think. That said, we do have a lot of resources we can help provide as well, in addition to our network of statewide heart team practitioners and associated support staff. So check out the resources. We'll send out the slides. Please fill out, by the way, the online surveys. There's a handout to get your CME and CEU credits. Please email us if you guys have any ideas, feedback whatsoever. It's greatly appreciated, and we'll incorporate that into our ongoing programs. And thanks everyone for coming today.
Virtual gallery walk. I've done that once before, so we'll try it out.
Yeah, maybe.
well, thank you to our guest speaker.
Thanks again to Dr. Schweitzer. Thanks again, everyone, for coming today.